Tokyolive
Tokyolive,
Endoscopy
Endoscopy 1.
Okay, welcome everyone. My name is Gary May from St. Michael's Hospital in Toronto, and I'd like to introduce the session today on the role of EUS in the diagnosis of pancreatic lesions. I'd like to thank Dr. Inouye for this opportunity to participate in Tokyolive 2021, and I'm very excited to be part of this. My co-moderator today is Dr. Norio Fukami from Mayo Clinic Scottsdale in the United States, and we'll be moderating and introducing our speakers. So to start, I'd like to hand over to Dr. Fukami, and he'll introduce our first speaker.
Thank you, Dr. May. This is my honor and a pleasure to be a part of the Tokyolive again. Let me introduce the first speaker, very well-known worldwide, Professor Masayuki Kitano. He's currently the professor and chairman of the second Department of Internal Medicine at Wakayama Medical University School of Medicine. He graduated from Tottori University, and then he was working for a long time in Kinki University, where he produced multiple papers, and we had a great discussion when I met you at Kinki University. I learned a lot about contrast-enhanced EUS, and you're the world expert on this subject. And he's the counselor and taking a very important positions in multiple societies, including JGES, and Japan Pancreas Society, Japan Biliary Association, and he's on editorial board, associate editor for Digestive Endoscopy, Clinical Journal of Gastroenterology, and International Journal of Clinical Oncology. He has multiple book chapters, numerous publications, and he's just a fantastic expert on this subject on pancreas disease and EUS. So that's my introduction. We have a great pleasure to have you, Masayuki.
Thank you very much, Professor Fukami, my best friend. I'm very happy to speak under the EUS chairman. And also, I appreciate Professor Inouye for giving me this great opportunity. So I'll present my presentation now. I'll talk about EUS with contrast enhancement and EUS elastography for pancreatic lesions. This is my COI. Diagnosis of pancreatic lesions with EUS include detection, characterization, staging, and tissue sampling using EUS FNA. Regarding detection, it is superior to the other imaging modality. This is the outcome of Japanese multi-center study in the 200 pancreatic cancer patients at stage 0 and 1. The depiction rate of pancreatic tumors using USCT and MRI are around 50%. On the other hand, the depiction rate of EUS is 76%, which is superior to the other imaging modality. This is a typical imaging of pancreatic cancer at stage 1A. MDCT and MRI shows narrowing of pancreatic duct. However, they fail to depict pancreatic mass. On the other hand, EUS depicted a low hypoechoic mass of 7 millimeters at the narrowing part. However, in the such kind of low echoic regions, we sometimes difficult to characterize them using EUS only. So therefore, for the characterizing these regions, image enhancement technologies, including elastography and contrast enhancement, play important role. EUS elastography includes strain and shear wave elastography. This is the principle of strain elastography. When the probe compress tissue, some distortion occurs. hard tissue has small distortion. On the other hand, soft tissue has large distortion. By calculating distortion, we can depict the tissue hardness in colors. Normal pancreas is depicted in green. On the other hand, pancreatic carcinomas are depicted in blue, which means less distortion in the tumor. This is a meta-analysis of EUS elastography for diagnosis of solid pancreatic masses. Since its sensitivity is 95%, I think it is very high. On the other hand, its specificity is only 67%. It is because it is sometimes difficult for us to discriminate severe chronic pancreatitis from pancreatic cancers. This is a principle of shear wave elastography. When the pulse path sent to the focal point, shear wave is generated. When we measure the shear wave velocity, we can measure the tissue hardness using this method quantitatively. This is the image during we measure tissue shear wave velocity. The harder tissue has the higher shear wave velocity. So then we analyze where the shear wave elastography for the useful for diagnosis of chronic pancreatitis. We set cutoff value of shear wave velocity at 1.96, and then we found that its sensitivity and specificity are 83 and 100% respectively. And also, we assessed whether the shear wave elastography is useful for severity of chronic pancreatitis. We measured the shear wave velocity in normal pancreas, chronic pancreatitis with endocrine dysfunction alone, with exocrine dysfunction alone, and both endocrine and exocrine dysfunction. And then we found that shear wave velocity with in the chronic pancreatitis with both endocrine and exocrine dysfunction is the highest among four modalities, four groups. So therefore, the shear wave velocity may reflect of severity of chronic pancreatitis. And then it is summarized of EUS elastography. Its benefits are high sensitivity in diagnosing pancreatic neoplasm using tissue hardness. And also, it allows us of quantitative analysis of tissue hardness in chronic pancreatitis. However, it has a limitation in the low specificity because it is difficult to discriminate severe chronic pancreatitis from malignant lesions. Then I go to the contrast enhancement. Ultrasound contrast enhancement consists of microbubble gas covered with lipids. The diameters of microbubbles are approximately 3 micrometer. When the microbubble receives a certain range in acoustic power, it has resonance. When the microbubble has resonance, it produces not only fundamental components, but also second harmonic components with high frequency. By depicting these second harmonic components, we can selectively depict signals of microbubbles. We classified vascular patterns of pancreatic solid lesions into 4 patterns: non, hypo, iso, and hyper-enhancement. 96% of hypo-enhancement are ductal cancer. On the other hand, 75% of hyper-enhancement are neuroendocrine tumors. This is a typical image of ductal carcinoma with hypo-enhancement. The diameter of tumors just 11 millimeters. You can see the thickness of the microbubble is lower in this area than the surrounding tissue. This is a typical image, tumor-forming chronic pancreatitis with iso enhancement. Left image shows us a standard EUS, which shows the low equipoise area at the head of the pancreas. When we perform contrast enhancement, we can see homogeneous enhancement without clear margin to surrounding tissue. This is a typical image of neuroendocrine tumor with high pro enhancement. You can see stronger enhancement compared to surrounding tissue. We can see that this is a small hypoechomasis other imaging method cannot identify. The diameter was less than 10 millimeter. When we perform contrast enhancement, we can see hyper enhancement in the upper one. So we can say this is a neuron-defined tumor. On the other hand, in the lower image, we can see hypo enhancement. So we can conclude this is a ductal carcinoma. We assessed meta-analysis for diagnostic ability of contrast EUS for pancreatic cancer. The sensitivity and specificity are 93% and 80% respectively. I think it is quite reliable. Then we compared contrast EUS and MDCT, and then we found these two imaging modalities are comparable in terms of diagnosing pancreatic carcinomas. However, when we focus on tumors of 2 centimeters or less, the sensitivity of contrast EUS is higher than the MDCT. So therefore, contrast EUS is useful for characterization of small pancreatic solid lesions. EUS FNA is also useful for characterization of pancreatic mass. However, it has sometimes limitation in small lesions. This slide shows diagnostic yield of EUS FNA of lesions of different sizes. When we talk about tumors of 10 millimeter or less, its sensitivity is just 73%. Then we compare EUS FNA and contrast EUS, and then we found that they are comparable. However, when we combine EUS FNA and contrast EUS, the sensitivity of EUS FNA increased 92% to 100%. So therefore, we can say contrast enhanced EUS is complementary to EUS FNA in identifying ductal carcinomas, particularly with EUS FNA negative findings. This article assessed whether the contrast EUS predicts difficult sampling during EUS FNA. They divided pancreatic solid lesions with 2 patterns, tumors with a vascular area and those without a vascular area. And then they found that more inadequate samples are obtained in the tumors with a vascular area. So therefore, the sensitivity of the EUS FNA in the tumor of the avascular area was just 70 to 73%. So therefore, presence of avascular area, which probably means the necrotic area, is the predictor of false negative EUS FNA findings. So then we tried to attempt whether the contrast EUS is useful for the targeted EUS FNA. When the area has heterogeneous area on the whole region, we just perform ordinary EUS FNA. But when we found non-enhanced area or homogeneous area, we had to avoid these regions to perform EUS FNA. And then we found in the latter 2 imaging patterns regarding adequate sampling rate and sensitivity, contrast enhanced EUS is superior to standard EUS FNA. So therefore, probably contrast EUS helps the targeted EUS FNA. I go to the cystic lesion. This is the IPMN. You can see echogenic structure in the cystic lesion. However, it is difficult for us to discriminate this area as the mural nodule or mucus clot. And then we performed contrast enhancement. You can see signals in the echogenic structure. So therefore, we can conclude this is a mural nodules. This is a typical image, mucus clot. In the left image, you can see echogenic structure, but we can see any signals or microbubbles. Therefore, we can conclude this is a mucus clot. Then we assessed whether the contrast EUS is useful for differentiation of malignant from benign cysts. We defined presence of mural nodules as a sign of malignant cyst. And then we found that when we compared standard EUS and contrast EUS, the sensitivity of standard EUS is quite high, 97%, but its specificity is just 40%. it means standard EUS sometimes fail to discriminate mucus plot from neural nodules. But when we perform contrast EUS, the specificity improved to 75%. So therefore, contrast EUS may improve the differentiation of malignant from benign cyst. Contrast EUS also useful for staging of pancreatic cancer. Sonazoid is a unique contrast agent for which Kupffer cell 5 sites, so which allows us Kupffer imaging of the liver. So we analyze whether the contrast EUS is useful for the identification of liver metastasis of pancreatic cancer. This is a small liver metastasis in the EUS. In the standard EUS, you can see any mass-like region, but when we perform contrast EUS, you can see small liver metastasis. After finding it, we obtained tissue samples by EUS FNA under the guidance of contrast EUS. Then we compared contrast CT, standard EUS, and contrast EUS for the identifying left liver metastasis. And then we found contrast EUS sensitivity is higher than the other imaging modality, particularly small liver metastasis of less than 10 millimeter. Among approximately 400 patients, in 9 patients, only contrast EUS detected liver metastasis. The median maximum diameter was just 3.5 millimeter. In these 9 patients, the staging of the tumor was changed to the stage 4, and also the clinical management also changed. So contrast EUS is maybe useful for M staging of pancreatic cancer. So this is a summary of contrast enhanced EUS. Contrast EUS improves the imaging technology on depiction of long-lasting, real-time parenchyma microfiltration and digital structure of the lesions, such as vascular tumor vessels, necrosis, and spotch. And then we can apply this technology for the characterization and detection of small tumors, and also identification of the target of USFNA. So in my conclusion, enhanced EUS imaging, including elastography and contrast enhancement, allows us to characterize the pancreatic solid lesions using fibrosis and vascularity. And it may be useful for the complementary role to EUS FNA. Thank you very much for your kind attention.
Thank you, Professor Kitano. That was fantastic. We don't have approved contrast agent in the United States, and I think Dr. May can talk about contrast agent in Canada, but I feel like I'm already an expert listening to your lecture. I want to get Q&A session briefly after your talk and after Dr. Steffi's talk, and then we'll all get together and discuss furthermore. Just one question among all many. You mentioned about contrasting EUS at 2% sensitivity to the FNA. Is that just only the imaging diagnosis? So the contrast EUS detected 2%, so make it 100% detection rate?
I see. I mean, sometimes the EUS FNA fails for the sensitivity. I mean, so sometimes, you know, the false negative sometimes happens. So in such cases, particularly the small regions, in such cases, maybe EUS FNA play complementary role, depicting hypo enhancement.
So the diagnosis 100% by contrast EUS addition means imaging diagnosis was most likely pancreas cancer, yes, even though FNA was negative.
Yes, right. Okay. As the hypo enhancement, right? Yes. Thank you. Thank you very much.
All right. Excellent.
Excellent presentation. Thank you. We also do not have any EUS contrast agents available in Canada, so I'm learning from you today. One question I had is that given that most of us now are doing fine needle biopsy of most solid masses in the pancreas, the studies that you showed in relationship to the advantages or the incremental improvement of using contrast agents over FNA, were any of those studies done with FNB, and do we know, do we have an advantage if we're looking at biopsy needles, which I think has become pretty much the standard of care in North America, at least?
Yeah, and I think of course, the improvement of the needles maybe improve the diagnostic ability of the EUS guided tissue samplings. I agree with it. And that time, I used the EUS FNA needle. So therefore, maybe EUS FNB needle may overcome EUS FNA outcomes. But anyway, I think, for example, when you focus on the small lesions, 1 centimeter, something like that, even though if you use the FADP needle, it sometimes fails. In such small lesions, maybe contrast enhancement may play the complementary role, I guess.
And just from a practical standpoint, from my knowledge, do you use contrast with every assessment for all pancreatic masses, or do you select certain lesions to use contrast enhancement for?
Thank you very much. A good, nice question. I think usually if the CT scan revealed hypovascular typical pancreatic cancer, I don't think we need a contrast enhancement. If you have the very subtle lesion, unclear lesion, we perform contrast enhancement, whether it has the hypoenhancement or isovascular or hypoenhancement, something like that. So, and then we decide whether we perform EUS-FNA after contrast enhancement.
Thank you.
Thank you very much.
Thank you so much. That we'll gather again after Dr. Setsu's talk. Okay, Gary?
Thank you. So it's my pleasure and honor to introduce Dr. Amrita Sethi. She's an associate professor of medicine at Columbia University in New York and is the director of interventional endoscopy and advanced endoscopy fellowship program at that institution. She completed her GI fellowship at the Medical College of Virginia and her advanced endoscopy fellowship at the University of Colorado. She's been an attending in advanced endoscopy at Columbia since 2008, and her practice interests include ERCP and cholangioscopy, as well as EUS, third space endoscopy with ESD, POEMS, and other endoscopic innovation. In addition to her work with the National GI Society, she's the founder and president of the Women in Endoscopy, a global organization started to foster mentorship and promote leadership for women in interventional endoscopy. So thank you for that. She's also the current president of the New York Society of Gastrointestinal Endoscopy, so very, very busy. This past year, she also received the ASG's Master Endoscopist Award, so we congratulate you. It's my honor to introduce Dr. Sethi and her talk on innovation in EUS diagnosis of pancreatic cystic lesions. So Amrita, thank you, and we look forward to your talk.
Thank you so much. And I thank the course directors for inviting me here today. And to Tokyolive, it's an honor. I've been looking forward to this. Hopefully live one day, I'll get to Tokyo. So I'll talk to you about innovation in EUS diagnosis of pancreatic cystic lesions. These are my disclosures. So as we all know, pancreatic cysts are really a big problem for us. They have quite a variable prevalence with up to 3 to 45% of the general population, with an increasing incidence with age. And why they are so important is because, in a sense, they are really the only identifiable precursor to pancreatic cancer that we have. And as we know, that's the third most leading cause of cancer. In fact, 17% of asymptomatic patients will have cancer and 42% will have a pre-malignant lesion. More importantly is that when we think about the treatment for pancreatic cysts or prevention of cancer with pancreas surgery, it does carry a high morbidity of up to 38%, as well as a mortality rate of up to 2%. And therefore, our goal with any of our management discussions regarding pancreatic cysts is really to figure out how to manage these in a way that we aren't sending patients to surgery who don't need it, but are establishing diagnosis of cancer early on. And therefore, we really focus on establishing a diagnosis, particularly between mucinous versus non-mucinous lesions, to then risk stratify. And most typically, these are between IPMNs versus MCNs, and then to help establish our management plan, whether it be surveillance or surgery. Here you can see in terms of the distribution of pancreatic cysts, the majority of cysts are mucinous lesions with IPMNs making up 30% and MCNs about 20%. The third most common is a benign lesion of the serous cystadenoma. So creating this distinction is very helpful in stratifying most of the cysts that we encounter. And the associated risk of high-grade dysplasia in cancer you see here is significant with MCNs and IPMNs, but negligible in serous cystadenomas, and again, helps guide our management strategies for our patients. And then, of course, we have a significant number of guidelines available to us throughout the world by various societies to really help us understand how we should determine risk factors for patients as to having mucinous versus non-mucinous lesions. When they do have mucinous lesions, what are their risk of malignancy and risk of progression, and how should we be surveying them versus whether we should send them to surgery. And all of these guidelines do have characteristic features that are definitive for high-risk features such as jaundice, clinical symptoms of pancreatitis, dilated pancreatic duct, and mural nodules, for example. But there are some features that are not universally discussed amongst these guidelines and leave some room for improvement with diagnosis to help us along the way. And so overall, what we try to do when we think about cysts is to really, again, diagnose in order to be able to determine whether they are cysts that we need to be worried about having malignant potential. If they do have malignant potential, is that a high or a low risk malignant potential? And how does that help us decide whether we should monitor or send to surgery and versus leave the patients alone and really not have to do any further monitoring? So traditionally, our diagnosis of pancreatic cysts have been based on some standard features of clinical history, morphology, for example, presence of ductal communication, and fluid analysis, and imaging. Today, we'll kind of discuss what are some innovative techniques that are now available to us, such as imaging that you just heard about with contrast enhancement, some new fluid analysis markers, as well as actually looking at the histology of the cysts alone. So traditionally, we can base our diagnosis on clinical features such as the age of the patient, location of the cysts, the morphology such as unilocular versus multilocular, presence of septations, presence of calcifications and location. Multifocality is very diagnostic for IPMN in most situations, and as well as communication with the main pancreatic duct. And we've established very standard imaging features of these various cysts, such as the mucinous cystadenoma versus a branch duct IPMN versus a serous cystadenoma. And these can be pathognomonic so as to have high accuracy in establishing, for example, serous cystadenomas that patients don't need any further evaluation. More importantly is the histology of these cysts, which are pathognomonic for all of them as they actually define the cysts. IPMN has several subtypes, which actually also help risk stratify the risk of progression within IPMNs into gastric, intestinal, pancreaticobiliary and oxycentic. Mucinous cystadenomas have this very characteristic single-layer ovarian stroma, and serous cystadenomas have this very typical cuboidal cell, which, if you're able to demonstrate this histology, can be diagnostic, and that's what we use as a gold standard in our pathological specimens. Our cyst diagnosis has typically been based on imaging and fluid analysis with very good sensitivities and accuracies in terms of imaging with MDCT in determining mucinous versus non-mucinous lesions. There's an accuracy of 80 to 85%. And as well as just cyst type in general, MCN versus IPMN. And in terms of accuracy of fluid chemistries, our typical chemistry is CEA. As we know, CEA of less than 5 is very sensitive for serous cystadenoma, while the CEA greater than 192 is more sensitive, suggests a mucinous lesion. Amylase less than 250 is very highly suggestive for a mucinous lesion, as well as it suggests lack of ductal communication. And then when we combine clinical variables such as history, as well as imaging and fluid analysis, our sensitivities for specific cyst types increases significantly, or is significantly high, with the sensitivity of 95% for benign lesions such as serous cystadenoma and 91 to 94% for mucinous. So how can we what we can find then is that about 10 to 30% of lesions still may have equivocal results. However, when you look at these ranges that are available and differences in imaging. And so the question lies in how we sort of decrease this difference and improve our ability to diagnose these cysts by adding additional factors to our conventional standard methods. Well, one biomarker that has recently gained significant attention, and this has been over the past 2 to 3 years, is the fluid glucose of the cyst fluid itself. And so in this meta-analysis that looked at 7 studies that measured the intracystic fluid glucose and found that the sensitivity when there was a glucose cutoff of less than 50 was 90% in diagnosing mucinous lesions, and with a specificity of 85.3%. And this was true for both prospective and retrospective studies, as well as the way in which the glucose was detected. And in this very recent systematic review as well, looking at the value of intracystic fluid glucose in determining mucinous versus non-mucinous lesions, 8 studies were looked at, 609 patients, and they found that the sensitivity of fluid glucose alone was significantly higher than CEA alone, with 91% versus 56%, with similar specificity rates, but a significantly higher accuracy in diagnosing a mucinous lesion. When used in combination, it did not make a difference. So that's fluid analysis. But as I mentioned, if we can really get to the tissue and the lining of the cells, this can be quite helpful for us in determining a diagnosis. And one way to do this is with optical biopsies, such as with confocal endomicroscopy, which is a technology that's been around for some time. It was originally used to look at Barrett's esophagus and then biliary epithelium. This is a technology that uses the IV fluorescein, which is injected. This is taken up by neoplastic tissue, and when a confocal laser is shone, the light reflected back provides near cellular images. So this is now feasible in cysts using a 2-millimeter probe that goes through a 19-gauge needle. There have been multiple trials to define these findings. As one would imagine, these are images that we have not seen before and therefore do require definition what they represent. These are the various types of various studies that have been done to not only define them, but also to validate the findings. And overall, they have been shown to have significantly high diagnostic accuracies, which I will show you in a moment, as well as excellent inter-observer accuracy. The risks associated with the procedure are few, but do include pancreatitis and intracystic bleeding, given the use of the 19-gauge needle as well as a device within it. These are, as I mentioned, this has been around for some time. These are all of the studies that have been done looking at confocal endomicroscopy for pancreatic cysts, the largest one being by Napoleon's group in France. And he has really done a lot of work defining these lesions, validating and determining the accuracies. So these are the actual images themselves. This is a mucinous cystadenoma with a very characteristic, what we think the single cell aligning of the ovarian stroma versus the papillary lesion or feature of an IPMN. This is a very characteristic finding for serous cystadenomas, this sort of tree branch pattern. And then the white bright spots you see here are very typical of a pseudocyst. And as you can see here, the diagnostic performance is excellent in determining, in diagnosing mucinous IPMN and serous cystadenoma, with the highest accuracies with serous cystadenoma with the specificity of 100%. This is a very, very characteristic finding. But as you can see, the accuracy even for MCNs and IPMNs is higher than 90%. So a very promising modality with a very high diagnostic yield. So that's optical biopsies, but what if we can actually get the tissue itself? These are the microforceps that are 4.3 millimeters in size and fit through a 19-gauge needle. And here you can see the type of specimen quality that can be obtained with the corresponding histology. As I mentioned, the needle goes in and you can see that come out. You can open and target any variable areas on the cyst itself. So I was fortunate to be part of this group looking at the value of tissue biopsy through the needle tissue biopsies and identifying mucinous pancreatic cysts. And we looked at 114 cases and found that the tissue acquisition ability to acquire tissue was significantly higher with the Moray forceps compared to FNA, as was the ability to actually diagnose a mucinous lesion. Furthermore, in cysts that had equivocal CEA values, 50% of those could actually be accurately diagnosed as mucinous versus only 8.5% with FNA. And when the surgical specimens were actually looked at for those patients that went to surgery, they found that there was a 100% concordance rate with the forceps biopsies compared to only 21% of FNA, which is also significant. And lastly, and very importantly, in 5 lesions in which advanced neoplasia was detected, 4 out of 5 of them actually were diagnosed by the forceps biopsies versus none by FNA, which is quite significant and does alter patient management if we think about it in terms of referring patients to surgery. Again, as we have to with every advanced technology, we do need to look at the risks, and they do include bleeding of 6% and pancreatitis 5.3%. In a recent systematic review that was done looking at 8 studies at 423 patients, the technical success rate was 95%, and the diagnostic yield was 75%. And here you can see the distributions of the different cysts, as well as an overall adverse event rate of 10%. And this was a very nice study done by the Mount Sinai group in New York that actually looked at the use of conventional cytology, standard diagnosis using clinical features, fluid analysis, typical fluid analysis, and imaging, and comparing that to the use of the forceps biopsies, as well as confocal endomicroscopy. And here you can see that the diagnostic yield of adding both the biopsy samples as well as confocal above the conventional method has significantly higher diagnostic yield, as well as what, or importantly, was how it changed clinical management. So using the combination, using forceps biopsies and confocal actually helped change management, including recommending stopping surveillance of patients, further imaging, repeating the EUS for further tissue, or actually sending patients for evaluation. And compared to the sort of conventional diagnostic methods of fluid analysis and imaging, the biopsy forceps actually changed management in 38% of patients, confocal in 43%, and the combination in 52%. And 3 out of 28 patients were actually referred to surgery who wouldn't have otherwise been considered to be need surgery. You've already heard an excellent discussion on contrast enhancement for cysts, and therefore I won't repeat that. I think the results overall are variable in the literature, and it seems that it will be likely most useful for non-neoplastic versus neoplastic cysts, in particular determining mural nodules, as you just heard from Professor Catano. So therefore, I will skip over this quickly. As he mentioned, it increased the specificity significantly. So I'll move on then to genetic analysis. We've conventionally known over the past several years that the epithelium does shed DNA, and we can measure this and look for genetic mutations such as KRAS, GNAS, and loss of heterozygosity. These have very high sensitivities and specificities for both IPMN and MCN, and the lack of GNAS is very specific for IPMN and not seen in MCMN. So these are very valuable markers for us, but more recent analysis is done now with next-gen sequencing, which has actually added significantly more genetic mutations. And we find that using this type of sequencing, both for KRAS, GNAS, as well as the additional genetic mutations, creates excellent sensitivities and specificities for IPMNs, in fact, significantly higher than just CEA values or features such as multiple cysts. And when we look specifically at cancer and advanced neoplasia, we find significantly higher sensitivities with these genetic mutations when we compare them to what our guidelines suggest as the dilation presence of mural nodule as features for high risk. So what's the future? What's coming? Well, as with in every area, AI and machine-based learning shows some promise. This is an interesting study. It's a little above my knowledge of AI, but I will just comment that it's basically a machine-based learning computation that takes into account all of these clinical features that you see here, listed here, that have been determined for all the different types of cysts, as well as looking at all of these genetic mutations. And when put together, they tried to basically determine whether this comp cyst computational analysis could help improve the ability to stratify patients into discharging them, continuing monitoring, or sending them to surgery. And they found that there was significantly improved rates, significantly higher rates compared to the standard of care diagnosis of fluid analysis and clinical history and imaging when this comp cyst was used in all 3 categories. But most specifically in discharging patients and continuing monitoring. And then furthermore, in determining the actual cyst type itself, you can see that there was excellent agreement in the comp cyst evaluation compared to the physician when compared to the actual pathology specimen. And then similarly, as I mentioned, AI is playing a role, and certainly this is an area where it's going to come into play. This study was very recently published, looking at using convolutional neural networks to assess the confocal endomicroscopy images, and found that they used two different models. Again, this is not something that I am very familiar with in terms of the modeling, but both models did show significantly higher sensitivities in determining the risk factor, the risk of cancer, as well as accuracy compared to both the Fukuoka guidelines and the AGA guidelines. And this is just, again, for those of you who are familiar with AI methodology and modeling, these are the two different holistic-based model and segmentation-based models that are available that were used for this study. So in conclusion, I think innovation in pancreatic cystic diagnosis is focusing on both the diagnosis, but more importantly, the risk stratification. Fluid glucose does show a promising marker for mucinous versus non-mucinous lesions, and it's questionable whether it may replace CEA and the value we place on CEA. Biomarkers are allowing for improved diagnostic of the cyst type, as well as the risk of progression. As you heard, contrast enhancement may have a role as well, particularly in determining neuronodules, which have been defined as high-risk features. And then tissue biopsy and optical biopsies may provide us with a very useful information, both in terms of pathology as well as risk for progression and tissue for genetic analysis. And in the future, I think this is a very ripe area for AI. So again, I like to acknowledge some folks who helped me out, and thank you very much for inviting me to be a part of this discussion.
Well, thank you, Amrita, for an excellent presentation. We've come a long way since the pancreatic cyst study that sort of gave us the CEA as the as the marker we should be looking at. Just a question, we're all deluged with patients with pancreatic cysts. So from a practical standpoint, what is your patient selection for like which patients, or what are characteristics about a patient or a cyst that would lead you to want to use the more advanced diagnostic modalities versus just a biopsy or just a fluid aspiration, or just being comfortable with follow-up without going to EUS or FNA?
Yeah, I think, one thing is that we look at all our patients in a multidisciplinary fashion. So sometimes it depends where the patient is coming from. Patients come to surgeons with a very benign looking cyst. They come to us, and sort of it's all about, really figuring out where they belong. And so I think sometimes that guides how aggressive I am. I think for the most part, being practical, I start off with the imaging, reviewing imaging, and if there's a significant consensus that it's a benign lesion, such as a serous adenoma, and the patient's not having any symptoms that would warrant considering surgery, then I don't even recommend EUS FNA, and I think that's agreed in our group. But if it does require initial analysis, I just start with the simple EUS FNA fluid analysis. I do send it for CEA, amylase, and for initial genetic markers such as KRAS and GNAS, unless it's a very clear IPMN, with multifocal imaging, multifocal assists and communication, then I think the value of that is very little, unless you see something that's concerning for, a mass or intracystic nodule. And I think we do have patients who come back with really equivocal results, or it doesn't quite fit the pattern. It looks like a it looks like a branch duct IPMN, but there's absolutely no communication. It's not multifocal, and the fluid analysis does not support that. And so for those, we will bring patients back and try confocal and/or biopsies. Our biopsies tend to be driven by our surgeons who are really debating, whether they should proceed with surgery. And a lot of it is also driven by patients. In the end, so much of patient cyst management is driven by patient anxiety and, concern for progression. And what I always find funny is that even when we lay out all this data for them, even then, if they know they're high risk, some still don't want to go to surgery. And some, when we tell them that they have absolutely no risk of progression, they absolutely want to go to surgery. So it's a fascinating field.
Amrita, that was a great talk. And you didn't mention about glucose in your routine practice. With those, accumulating data that's showing really good sensitivity, specificity, and some studies said additive benefit to the CEA. Do you think for the next 5 years, we should be checking glucose routinely?
Yeah, I do. We've been following sort of a standard pathway at our institution, oftentimes because our labs initially wouldn't even run CEA unless we had a certain amount of fluid. So we were obtaining that when we sent fluid for our genetic analysis. And glucose was not a part of that. I actually, particularly after preparing for this talk, I do want to go to my lab and sort of set up a way for that to be a routine part of our testing. I think it's going to take on a significant importance. And, I think the CEA has really thrown us for a loop sometimes, especially when you see very high CEA levels. There's really nothing to do with that other than no, it's a mucinous lesion. It doesn't help us determine the risk of malignancy necessarily. And so if something as simple as a glucose can really help us with that same question of mucinous versus non-mucinous, I think that's what we should be doing.
Great. One more question. So the molar forceps, you mentioned briefly about the subtypes of IPMN, and UCI group showed that the prediction of subtype is also possible with molar forceps. Do you see the benefit of classifying IPMN? Sometimes there's a combination of those subtypes within the IPMN, but what is your opinion?
Yeah. I do think so. There are some technical issues about being able to use those biopsy forceps. For example, the position, it's most ideal. You're using a 19 gauge needle, and it does stiffen the needle a fair amount. So using it in the head and the uncinate process can sometimes be difficult, where a lot of these lesions are. Also, if we know what we know about the cystic lesions is that the presence of that tissue is variable on the wall. And so it's not that it's uniformly lining the cysts. So I think that if we clearly see and know that there is some tissue there, and we see some others, for example, other factors that are concerning for helping us to determine the risk, such as either increase in size, perhaps, which doesn't currently have a role in determining risk of malignancy, then I think that could be helpful in patients who we know have IPMN to help us determine their specific risk.
Great. I want to throw this same question to Professor Kitano. So, Masayuki, what do you think? Is it to getting the subtypes classification? Do you think that will play a role in the future, or it doesn't really matter?
Yes, I think some genetic disorders are different among the 4 subtypes. So I think if we get to the gene using NGS, probably we can discriminate between them. I guess so. But unfortunately, in Japan, as you know, we don't puncture the cystic region. So it is difficult for us. Probably from the transpapillary, maybe we take the samples from the IPMN.
So the no FNA policy is still continuing on in Japan.
Yeah, actually, right.
Because of the concern for leak, correct?
Yes, tumor seeding
tumor seeding.
I'd like to ask you, three of you, did you experience some needle tract seeding or dissemination of the EUS pene or pancreatic cystic lesions in USA?
I have not. I have not, but I certainly have had episodes of pancreatitis in some situations, but I have not experienced the seeding.
Very okay.
Gary?
Not from cystic lesions, no. Although we tend, the ones that we spend time on are sort of the cysts that are indeterminate. I think if we see a cyst that clearly has malignant features or very high risk features, that we wouldn't necessarily biopsy that patient. That patient would be referred for surgery. It's sort of these 2 to 4 centimeter cysts that, where the diagnosis is indeterminate, that I think we spend our time on trying to define a little bit better. We don't have genetics easily available to us, so we're still left with, fluid analysis and biopsy. So we use intraductal biopsies occasionally, but it's very selective. Apart from some pancreatitis, we've been lucky, and I'm not aware of any needle tract seeding, but again, we don't biopsy cysts that appear to be very, very high risk.
I see. I understand that you take samples in the patient with indeterminate lesion, right?
Yes.
I see.
So Masayuki, there's no report per se in the literature, but Amrita and I were in Colorado together, and I think that same time frame we had one case who had drainage of the mucinous cyst. That patient came back with the mucinous pseudomyxoma peritoneae in later time. So I think there was a possibility that they connected. Drainage was the more aggressive form of FNA, but FNA probably still lower risk for tumor seeding. That's what we believe.
So even though you use the 90 gauge needle, right?
I prefer not to, but Amrita seemed to be not afraid of 19 gauge.
No. I mean, my typical needle for a cyst FNA is a 22 gauge. I do not typically use a 19 gauge, and there have been studies looking at, whether the difference in diagnostic yield, and there is no for cysts. There is no significant difference, just a difference in time to aspiration. But I stay away from 19 as well, unless trying one of these more advanced techniques, which again, as Gary pointed out, is rare, and I tend to do it also when it's an indeterminate lesion cyst.
Okay, thank you.
I'd agree. Our approach is the same.
I see.
I'm probably doing cyst aspiration now much less than we did 5 or 10 years ago. I think we're more reliant on the appearance. We test our imaging and the EUS features, and we're only really aspirating those where it's unclear, and for either patient factors or clinical factors that the aspiration will help us change management or alter management.
I see. Okay, I will consider later
sampling. So back to you, Masayuki. I have several questions. So you showed us a really nice data. It's natural that combining those modality improve the diagnosis. Let's say the elastography, contrast EUS, FNA. But you haven't combined, you didn't have the data to combine all these modalities together. Are you working on to see if all three modalities combined, you're going to be close to 100% sensitivity, specificity?
Thank you very much. It's a nice question, and probably all the people wonder how to do it. I think that usually the elastography has the high sensitivity, although it has specificity low. So I think if you perform the elastography, first you have to pick up the possibility of pancreatic cancer first, and then we perform the contrast and as well as EUS pene to confirm whether it is ear or pancreatic cancer or something like that. I recommend such kind of procedure. But so far, I have never combined them together because sometimes EUS elastography has the false negative, and sometimes the contrast is a false negative. When we combine sometimes and or we have to consider which is a better elastography and contrast, or elastography or contrast, something like that. It differs a lot. It is complicated. So therefore, I didn't analyze about that.
Okay, thank you.
Norio, I would probably say that this is another area that's going to be ripe for something like AI or machine-based learning is actually taking those images and helping to break them down, and also looking when you combine the different modalities, how does that determine your diagnosis and risk? And it's because I think it's beyond us to be able to calculate that. And then adding in fluid analysis perhaps would give you two different ways, a non-invasive as well as an invasive AI system.
Probably, yes. Imaging also, maybe.
Yeah.
Yes. Thank you very much.
Masayuki, so the shear wave is absolute data. The stress elastography is relative data. I mean, this is the basics of this, how you acquire this stiffness. So this relative stiffness, the compression or strain elastography, has been very difficult to use because of this the ROI determination can throw all this measurement off. Do you think this compression or stress strain elastography will be going away? Will shift into shear wave?
Thank you very much. Good, nice question. Actually, for the analysis of the pancreatic solid tumors, unfortunately, the shear wave elastography has limitation because the shear wave elastography needs wider range of the region to measure the velocity, unfortunately. So for the discrimination, benign and pancreatic tumors, still strain elastography is more useful. But for the measurement of the just elasticity in the whole pancreas, shear wave elastography is superior to the strain elastography.
Right, because the strain elastography is always just comparing within this window.
Yes, right. So it is a limitation in the measurement of the absolute quantitative analysis.
Exactly. One question, technical question. So the harmonic echo that is available in the United States as well, do you use separate setting for contrast EUS using harmonic? It's different, slightly tweaked version of harmonic echo?
Yes. You mean the specific mode we need, you mean? Yes.
Correct.
Yes, we need. We need a second generation contrast agent as well as specific contrast harmonic mode. But usually in the Olympus and the Fuji and Pentax, all of them has the specific mode for the contrast enhancement. So you don't have to worry about it if you have high-end ultrasound processor for the US.
Great, thank you. Since we don't have the contrast agent, they're not releasing those specific modes. So that I was curious.
I see.
Yeah.
I guess in the GE Healthcare in USA produce Sonazoid. So I hope in the USA you can use in the future.
Yeah, there's no specific indication for pancreas, unfortunately, but we'll see.
We see, yeah. For the liver, it's available, right? For the liver. I see.
That's correct.
I see.
Any questions from Gary?
No, I think I'd like to thank both of our speakers. I think it was a wonderful session. And again, thank you to Dr. Inouye and the organizers of Tokyolive 2021 for having us all participate in, I think, what was an excellent session on EUS diagnosis of pancreatic lesions. So again, thank you all, and we hope to see you all live in different venues around the world soon.
Absolutely. Thank you so much. It was a great talk. Nice
Thank
session.
you.
Thank you very much.
Bye.